I'd like to call the meeting to order. Of the first of all, are there any subs to report? Wilson for Michelle Conroy. Okay.
Thank you, Mr. Chair. Megan Mitten for Kevin Arsenault.
Thank you. Yes, he's missing. Thank you. Thank you.
Mr. Chair, Brian Collins for Richard Ames.
Collins for Ames. Okay. Is it the pleasure of the committee to take into consideration Bill number 3, an act respecting surgical facilities? All those in favor, please say yay. All those opposed, please say nay. I declare the motion carried. Mr. Minister, would you have any opening comments and introductions for the committee?
Sure. Thank you very much, Mr. Chair. And on my right is Ian Watson, ADM and Health. Behind him is Neil McKay, Director of Policy. And directly behind me is David Garris, Senior Policy Advisor. Did I get that right? Garris. And I appreciate them joining me here today to help defend Bill number 3. And just as opening remarks, Mr. Speaker, I will just give a brief recap of what this amendments to the regional is what's being proposed here today. Is to make amendments to the Regional Health Authorities Act and the Medical Services Payment Act, which will enable the health system in New Brunswick to provide for the delivery of surgical services outside of a hospital. New Brunswick's population is aging, of course, as everyone knows, and with nearly 20% more seniors than the rest of Canada, the gap is expected to grow. Based on current projections, nearly 1/3 of New Brunswick's population will be over the age of 65 by late 2030s. The need for surgeries such as cataract and hip and knee replacements will continue to increase. So our government is working to address barriers to allow for quicker and more efficient delivery of identified surgical services with the aim of clearing surgical backlogs, reducing wait times, and freeing up hospital operation rooms for more complicated surgeries that must be done in hospital. So these legislative amendments will support a pilot project underway in the Bathurst regions doing cataract surgeries. Merci beaucoup, Monsieur le Président.
Thank you very much, Minister. At this time, would there be any questions or comments on the bill? I'd like to recognize the member from Edmundston, Madawaska Centre.
Merci beaucoup, Monsieur le Président. Je tiens à remercier le ministre et puis les gens de son ministère qui pourront le supporter, l'appuyer à répondre aux questions du projet de loi numéro 3. J'aimerais quand même, en entrée de jeu, que le ministre nous fasse une explication un petit peu plus précise quand on parle, le ministre a parlé de modification, entre autres, de la loi sur les régies, un projet pilote d'établissement de services, dans ce cas ici, de chirurgie de la cataracte à l'extérieur du réseau de santé. Donc, est-ce que le ministre peut donner un peu plus d'informations sur de quelle façon que chacun des bureaux ou quel sera le lien entre le gouvernement provincial, le ministère de la Santé, les régies, dans ce cas ici la régie de santé et vitalité, et le bureau où est-ce que les chirurgies de la cataracte auront lieu.
Merci beaucoup pour votre question aujourd'hui, through you, Mr. Chair, to the member opposite. And again, just in a general overview, the legislative amendments are being introduced today, which will allow a pilot project on cataract surgeries to take place. And this pilot project is a relationship between Vitality, the RHA Vitality, and the office, or the third-party provider, which is affiliated as well and in agreement with Vitality to perform these cataract surgeries. And it is in a setting that is outside the bricks and mortars of the hospital in the region. And basically this legislation that we're proposing here today will allow that pilot project to take place. So I did go and visit the clinic myself and saw the success that was occurring. And again, the acts before limited any of these types of surgical procedures to take place within the boundaries of the hospitals. Now, this pilot project and this change in legislation allows those procedures to be done at clinics outside the bricks and mortars of the existing hospital. Again, it's a service that, again, agreement between Vitality and the provider. And also, people should know that it is covered under Medicare, so it's not a procedure that people have to pay for out of their pocket. It is paid for by Medicare, and again, this will free up some surgical rooms within the hospital to do some of the more complicated surgeries, such as hip and knee, and some of the cancer surgeries as well. Sorry, just I don't know if you can hear it on the mic, but the heater's cranking up. I have some competition, but I'm sure with the microphone, people can hear me. So, so that's basically a high-level overview of what is occurring, and I know we can delve down deeper. Be happy to answer any questions further to that.
Président, merci, Monsieur le Président, et merci au ministre pour son début de réponse. Honnêtement, Monsieur le Président, je pensais qu'il était en train d'avoir un tintamarre du côté du gouvernement. Et puis, mais là, on comprend que c'est le système de chauffage, mais probablement que c'est les astres du côté du gouvernement réagissent et puis s'assurent que le ministre puisse se rappeler pour longtemps de la loi sur les langues officielles. Et puis, je vais revenir un petit peu plus tard. Donc, les gens de son ministère pourront se préparer en conséquence. Je reviens sur les commentaires du ministre concernant le terme en anglophone « third party ». Parce que ma question était, quel est le lien, quelle sera la responsabilité ou le lien obligatoire entre le ministère de la Santé, la Régie et le bureau privé qui va faire des chirurgies de la cataracte? Est-ce que c'est seulement un bureau qui sera là et puis qui va facturer, tout simplement? Est-ce qu'on va continuer? Est-ce qu'il va y avoir une référence de la part de la Régie, donc des hôpitaux, que ce soit, on va prendre Bathurst à titre d'exemple, parce que le bureau sera situé à Bathurst, mais est-ce que c'est la Régie qui va référer? Est-ce que ça veut dire que la Régie ne fera plus d'opération de la cataracte pour la région donnée? Donc, le lien encore, le lien. Et puis, le lien d'obligation de service. On est-tu en train d'établir, est-ce qu'on est en train de décharger? Est-ce que le ministère et la Régie sont en train de décharger complètement ses responsabilités vers des cliniques privées? Ou est-ce que ça va être un modèle hybride? Je comprends que c'est un projet pilote, mais il faut quand même arriver avec des intentions puis bien comprendre l'intention derrière le projet de loi. Donc, je vais laisser la chance au ministre de vérifier ses notes, de parler avec ses gens, mais je pense qu'il faut bien saisir l'importance entre le ministère, entre la Régie, par rapport à cette clinique privée.
Merci beaucoup, Monsieur le Chair, through you, pour le député Fass. Ça, c'est une bonne discussion pour un dossier très important pour les citoyens de Nouveau-Brunswick. Maintenant, c'est le citoyen qui demeure à zone 6 qui est fait, qui être referred, make a referral into the clinic. So the people in Zone 6, in that region particularly, in the Bathurst area, which includes some of the surrounding areas as well, can be referred into, and it's the clinic is run by Dr. Givandi, and the normal billing process, as they did when they were as a doctor would do when they were in the hospital, submitting the claims into Medicare, and Medicare compensates the doctor on a fee guide, and as the normal practice was when the services were done within the bricks and mortar of the hospital. But I think it's important to note too, and I know I'm digressing a little bit, but optimizing that the cataract surgery services, it's going to eliminate some of the pressure on the Chaleur Region Hospital. And it's going to give more time for more operations to be completed in the hospital itself. So when you look at the wait times, cataract surgery was the highest in the province for wait times. And the wait times were almost a year and a half, which again, if you're experiencing an issue with your eyesight, that's very, very difficult. So it's, and again, when we visited the clinic, there was a number of patients lined up, and we talked with the patients, and you know, they were very pleased to be able to get in so quickly in order to get the work done on their eyes. And it was great to have that conversation with them because they seemed so pleased for this facility. So having those patients at that clinic as opposed to in the hospital, again, now allows some of the other items which have long waiting lists, long as in number of people on the list, but also long wait times for knee and hip, and even cancer surgeries, but the ones that had the longest after the cataract surgeries were the hip and knees. Will allow more of those to be done in the Chaleur region, which is good news. Because again, it's when you've got a situation and you need to have that medical treatment, and it's been a hot topic here in the legislature for many, many years, and it's not unique just to the province of New Brunswick that we have wait times. It's right across Canada. So this is a step forward, and again, it's a good step forward, and it alleviates some of the backlog, some of the pressure, the wait time for people's waiting for this service.
Merci, Monsieur le Président. Au ministre, j'ai compris qu'est-ce que le ministre a mentionné, que ça va être un projet pilote pour la zone 6. Ma question, est-ce qu'à l'hôpital régional Chaleur, il va encore y avoir des opérations de la cataracte, ou bien que ça va être seulement et uniquement la clinique privée qui va pouvoir faire les opérations de la cataracte pour la zone 6?
Merci beaucoup. Ça, c'est une autre bonne question. Et c'est vrai, le jour de jour opération pour l'hôpital de Chaleur, c'est la décision pour l'hôpital. Et le géré qui fait cette décision, mais fait la décision pour si il y a plusieurs personnes qui ont besoin de surgery de cataracte, then the hospital would make that decision of adding more surgeries in the hospital proper. But really the win for this, because Dr. Giovanni will be doing many more surgeries. I'm going from memory here. I think it's about 75 a week versus about 60 or versus about 36. So almost doubling the number of cataract surgeries that were being done in the hospital will be done in the clinic. So it's going to reduce the wait list. It's going to reduce the wait times much quicker than doing it in the hospital. And when I toured the hospital and talked to the CEO there, or the manager, they said that they really want that space that's freed up for hips and knees, because again, those lists are long and the wait times are long, but this move will allow those wait times to be reduced and the list to be reduced. So that's how the nuance occurs. So the decision on whether or not to have additional cataract surgeries in the hospital would be up to the local decision makers, but in the discussion I had with them directly, it was that they will be using that freed up space for other operations.
Merci, Monsieur le Président. Je comprends qu'ils vont libérer des espaces. Est-ce que le ministre pourrait nous expliquer pour quelles raisons? Plutôt, je reviendrai un petit peu plus tard sur cette question-là. J'aimerais savoir, à part de la clinique privée, il va encore avoir des chirurgiens pouvant faire des chirurgies de la cataracte à l'hôpital Chaleur. Donc, combien de chirurgiens pouvant faire des opérations de la cataracte vont être à l'intérieur du système de santé, donc à l'hôpital Chaleur? Parce que ce que je comprends, c'est que le ministre dit, puis le fond de ma pensée dans ça, c'est que le ministre dit, c'est pour pouvoir libérer des espaces, pour pouvoir faire des opérations de d'autres chirurgies, c'est bien. Mais est-ce qu'il y a encore des chirurgiens qui vont demeurer à l'hôpital Chaleur? Donc, qu'est-ce qu'eux vont faire? Parce que c'est pas une chirurgie, un chirurgien pour la cataracte, c'est pas la même chose qu'un chirurgien pour une hanche, à ma connaissance. Donc, je vais laisser le ministre répondre.
Merci beaucoup. Ça, c'est une bonne question. Et quand je fais une tour de l'hôpital de Chaleur, je n'ai pas parlé avec une autre médecin qui dit ça, c'est une mauvaise idea. So when I toured the facility, there were no other doctors that came to me. Or even sent an email or contacted the staff or anything that said, oh, this is going to hurt my pocketbook, or this is going to hurt the things I do. So if the member opposite has, some information, or some of the doctors that have come to him personally and are concerned about that, again, we can alert the local decision makers on that concern, but I'm sure that they've voiced it directly if that is the concern. But it's certainly this clinic, this legislation, what we're talking about today, doesn't preclude any other surgeons from doing particular cataract surgeries in the hospital. But it comes back to that local autonomy, the local decision makers, and the conversation I had with them. They are hoping or wanting to use that space for other surgeries that have a backlog as well.
Merci, Monsieur le Président. Mon inquiétude n'était pas nécessairement à savoir si des médecins ou des chirurgiens allaient faire moins d'argent, mais c'est de voir s'il allait y avoir des chirurgiens ou des spécialistes de la cataracte qui pourraient tout simplement décider de quitter la zone 6 pour aller travailler ailleurs. Parce que lorsqu'on arrive, on comprend que c'est un projet pilote, mais spécifique à la cataracte. Donc, sans que le ministre ait eu à parler ou qu'il n'ait pas eu la chance de parler avec d'autres spécialistes du domaine, et lorsqu'il a fait la visite de l'hôpital, ça demeure que c'est un projet pilote. Donc, le projet pilote devait certainement identifier les pour, les contre, les risques. Puis c'est pour ça la question. Donc, combien d'autres je vais poser la question différemment, combien y a-t-il actuellement de chirurgiens de la cataracte à l'hôpital Chaleur? Peut-être ça va être plus simple pour une réponse plus simple.
Mr. Speaker, the particular bill that we're discussing here today doesn't deal with the human resources that are managed by the Vitality, so we don't have that specific number. I can take that under advisement, and once we have it, we can give it to the member opposite.
Merci, Monsieur le Président. Et puis, je pense que oui, le ministre devrait revenir avec une réponse, parce que si il existe des chirurgiens actuellement à l'hôpital Chaleur, puis ils décident de quitter à cause du projet pilote pour aller travailler ailleurs, puis que là, on n'a plus d'autres chirurgiens à l'hôpital, il y a la clinique privée qui est un projet pilote. Projet pilote, c'est certain qu'il va y avoir des investissements, donc probablement projet pilote, mais plutôt garanti autre que n'importe quoi d'autre. Mais s'il arrive une situation avec cette clinique privée pour des chirurgies de la cataracte, et puis que les chirurgiens de la cataracte qui avaient à l'hôpital Chaleur auront quitté, on arrive avec quoi? Donc, c'est quoi en anglais, c'est quoi le backup? Est-ce qu'on a une garantie que des chirurgiens actuels vont être là? Puis encore le nombre. S'il y en a 2, il y en a 3 à l'hôpital Chaleur, mais il faut être certain qu'on puisse avoir un équilibre, ou sinon, qu'est-ce qui arrive? On ne sait pas qu'est-ce qui peut arriver. Donc, le ministère, je suis surpris un petit peu que le ministère, arrivant avec un projet de loi, ou le ministre arrivant avec un projet de loi de ce genre-là, n'a pas ces informations-là. Ou il devrait tout de moins avoir ces inquiétudes.
Monsieur le Président, c'est la même réponse. It's the same response, Mr. Speaker. We said we'd take this under advisement because this particular bill is not about human resources. The management of human resources is managed by Vitality. So again, I've been generous to say I'll take that under advisement and get back to him. But again, the feedback that we had was that the wait list was long. And I think the member opposite has to take a good understanding of who he wants to side with. Does he want to side with the patient needs or the needs of some doctors? And again, if he's got some specific doctors that have come to him with concerns, we're more than happy if he wants to give us those names and contact, that we can have that discussion through the RHA, through Vitality, to listen to their concerns. Because there is, definitely opposition or opportunities for again, doctors within the province of New Brunswick. And when this pilot project was going forward, the concerns from other physicians did not come forward. There were no other physicians that came forward to us to say, this is going to hurt my pocketbook. The concern that we were addressing, which I think is most important, was the wait times and the number of people waiting for cataracts. That's where we sided on, was the side of the patients. The patients, the people in the province of New Brunswick, they were the ones that were waiting. They were the ones that the numbers were increasing for the wait time. This particular pilot project, again, that's the reason behind the pilot project, calling it that, is to see if there, again, if it works as expected, you'll see wait times reduced. You'll see the patients in the province of New Brunswick getting better care. And that's the goal. That's the goal of this particular bill, is to allow for these procedures to take place at a clinical setting, which again frees up the operating room for other doctors. So again, if the member opposite is just concerned about the physicians, there's other physicians that now will be doing more surgeries. So in fact, the fact that there's more hip and knees being done may actually attract more doctors to the area, to the argument that's being made. And again, what we're seeing here is that overall, this will help the residents of New Brunswick, this will help the patients of New Brunswick, and not just the cataract surgeries waiting, but the hip and knee and actually cancer research. That's the information that was given to me when I talked to the CEO of the Bathurst Hospital. They were very excited, very receptive, and anxious to get it going.
Merci, Monsieur le Président. Je pense que le ministre n'a pas l'air à comprendre. Ma priorité numéro 1 est certainement le patient. Mais le point est, s'il arrive quelque chose à la clinique, puis tous les chirurgiens de la cataracte qu'il y avait à l'hôpital Chaleur sont partis, qu'est-ce qui va arriver aux patients et aux citoyens? Ils devront se diriger ailleurs. Je veux dire, c'est pas sorcier, là. Donc, c'est simple comme question. Donc, même si le ministre continue à répéter ma question semble se diriger vers le compte de banque des professionnels de la santé, c'est nullement le cas. Je pense aux patients qui sont obligés de se déplacer à tous les jours pour pouvoir avoir des services à l'extérieur de leur région parce que les services ne sont plus disponibles dans leur propre région. Mais bon, je vais passer à autre chose. Puis si j'ai besoin de répéter ce que je viens de dire à un autre moment donné, ça va me faire plaisir de le faire. J'aimerais que le ministre nous donne la date à laquelle il a fait l'annonce pour la clinique de chirurgie de la cataracte, et puis qu'il nous dise aussi les débuts pour la première opération. Est-ce que le ministre peut nous donner cette information?
Thank you very much, Mr. Speaker. And I'm going to look up the date. It'll just take a moment, but maybe the member opposite can ask his colleagues, the members from Bathurst West, Beardsford, and Bathurst East and Pisiquid, what date that they attended the opening. And if that's the date that he's looking for, he can ask his colleagues who attended as well. So again, just looking for some of those dates. May take a minute, but we'll just take that under advisement for a moment, and I'll look in the calendar to see what date we're up there.
Merci, Monsieur le Président, mais en tout cas, ça ne devrait pas être si compliqué pour le ministre d'arriver avec son calendrier. Pas besoin de demander à un autre député. À cette heure, est-ce que le ministre il va nous revenir avec la réponse de son annonce? Est-ce que le ministre peut nous donner la date à laquelle la première chirurgie a eu lieu ou aura lieu?
Je m'excuse, Monsieur le Chair, pour le député en face. I thought he was saying, when did we make the announcement of the opening of the clinic? And two of the Liberal members were there as well, and that's why I was saying if he wasn't. I was going to look it up here, again, to be accurate, but he could have asked one of his colleagues that question as well. Anyways, not to be argumentative, the first surgery started on the week of September 5th.
Est-ce que le ministre peut juste peut-être répéter, Monsieur le Président, est-ce que la première chirurgie a eu lieu la semaine du 15 septembre, c'est bien ça? Ou la semaine du 5 septembre, plutôt?
5.
Est-ce que le ministre, Monsieur le Président, peut maintenant nous expliquer si la première chirurgie a eu lieu la semaine du 5 septembre? Le projet de loi a été déposé le 26 octobre. Est-ce que le ministre peut nous expliquer pourquoi, après l'annonce pourquoi après la première chirurgie du 5 septembre, le ministre fait l'annonce à un moment donné qu'il va finir par nous le dire, le ministre arrive avec un projet de loi le 26 octobre 2022, donc près de 2 mois après la première chirurgie, donc qui veut dire que toute la planification était faite à l'avance. On ne fait pas la première chirurgie du jour au lendemain. Donc, est-ce que le ministre peut nous expliquer pour quelles raisons qu'il avait besoin d'un projet de loi suite au début des opérations?
Mr. Speaker, the clinic and the government was operating in the best interest of the residents of New Brunswick, best interest of the clients, best interest of the people that were on the wait list. Again, with the pending legislation and decision of Cabinet that was, again, allowing for this legislation to go forward, that's why, with anticipation that, which is, again, a lot of policies change as time goes on, and a lot of times the implementation of those policies go forward before a public announcement or before a press conference or before a ribbon cutting. So it's not anything out of the ordinary, though I'm sure the member opposite will try to make it very nefarious. But again, Dr. Giovanti and the government is acting in the best interest of the patients who had been on the waiting list looking for better eyesight for almost a year and a half. And again, that issue hasn't been an issue until now. So, but it's, you know, there's other situations that I've known about in the past where, again, policy and action has gone forward before the legislation has caught up to it.
Merci, Monsieur le Président. Est-ce que le ministre peut nous dire à quelle date approximative, on va aller avec le mois et l'année, que le propriétaire de cette clinique a débuté les négociations avec la régie et ou le gouvernement provincial, et la date approximative, encore une fois, où est-ce que l'entente a été signée entre la clinique et puis la régie et ou le ministère de la Santé.
Thank you very much, Mr. Chair, through you to the member opposite. And again, just a point of clarification. This is a contractual agreement between Vitality and the doctor who's made the investments in order to put that clinic up. So those discussions, and they occurred well beyond any ribbon cutting or well before the date and time that that those surgeries started. So just to be clear, this is an agreement between Vitality, the RHA, which is tasked with the mandate of the day-to-day operations, the clinical operations of health services here in the province of New Brunswick. But the discussions with Dr. Giovanti, my understanding took place or started quite a number of years before any operation was completed.
Merci, Monsieur le Président. C'était mon point, hein, en bout de ligne. Le ministre a dit que c'était pour essayer de solutionner les temps d'attente au niveau des chirurgies de la cataracte et aussi au niveau des genoux et de la hanche. Il parlait qu'il fallait solutionner le problème, un problème d'1 an et demi. Premièrement, c'est un problème de pas mal plus qu'1 an et demi. On vit ça depuis les 4 dernières années à un niveau assez élevé, puis pas seulement à cause de la pandémie. Donc, si la régie est en discussion avec le médecin en question, plusieurs années avant que la première opération arrive, est-ce que le ministre peut nous expliquer pourquoi il nous arrive avec un projet de loi seulement le 26 octobre 2022?
Thank you very much. And Mr. Chair, again, you know, the important work is done in the negotiation of a contract to figure out exactly how is this clinic going to operate. And there are a number of different combinations or permutations of how a contract could land, especially when you have the RHA dealing with a third-party contractor. Because it could have been that Vitality would own the building and the doctor would lease back or rent space from Vitality, or it could be that the doctor would make the investment and Vitality would contract the services. There are a number of different ways that those contracts would take. And again, it's very similar to other contracts that are negotiated by the RHAs from you know, masks to bedpans. And, but this was one different that had to, again, take into consideration the legislation. And that's why once the Vitality and the doctor settled on what kind of contract would work for satisfying both needs, the needs of the patients, the needs of the doctor, or the you know, desire for the doctor to fill a need, and some of the, again, Vitality's needs of having these backlogs of patients and trying to alleviate that patients. How do we get that done? So there's, again, it's normal operations that Vitality would enter into a contract, and then if the legislation needs to catch up, that's why it was put on at the timing that it was, because the negotiations had been fulfilled, the contracts had been worked out, and again, having to take into consideration, okay, now what legislation does that needs to occur to make this go forward? And again, with this legislation that were put in place to create a pilot project, again, that makes it it's the best way to move forward, in my opinion, and that hopefully explains some of the differences in dates that the member across the way is trying to clarify.
Merci, Monsieur le Président. Est-ce que le ministre peut nous donner les détails? Quel est le lien entre les détails de la signature de l'entente entre Vitalité et le projet de loi qu'il a présenté le 26 octobre?
Thank you very much, Chair, through you. And again, the point of discussion here today is Bill number 3. And Bill number 3 isn't an examination of the specific contract between Vitality and Dr. Javante. This is the framework that, again, allows payment to be made to a physician or to a clinic, in this case a specific clinic, outside the bricks and mortar of an existing Vitality facility. So again, I know the member may have had a number of questions on the contract, and again, many times those contracts between Vitality and their service providers are something that could be questioned at Crown corporations when Vitality comes in or when the RHAs comes in. And again, there's also some competitive information that may or may not be available to the general public for, again, consideration of the company that's providing services, whether it's masks or bedpans, and in this case, the particular clinic. So I guess the discussion today is not to analyze the specific contract, but basically looking at the legislation that, again, expands the payment ability of Medicare and for Vitality to pay the doctor, this particular doctor, for services that were needed by the public. So I guess that's looking for clarification, I guess, as to where the member wants to land or where the member wants to discuss, because some of that discussion might be for another day, but today it's Bill 3. Again, creating that the framework under the various acts, the RHA Act and the Medical Payments Act, in order to have these procedures go forward, which would again reduce the significant wait lists in the particular zone we're talking about.
Merci, Monsieur le Président. Je ne veux pas mettre de mots dans la bouche du ministre. C'est le ministre qui a dit qu'il fallait attendre que les détails du contrat soient finalisés afin de pouvoir présenter un projet de loi, là. Donc là, tout d'un coup, ça change un peu. On peut durer longtemps, là. Je veux juste quand même passer un message au ministre, là. Si on n'a pas de réponse claire puis on veut juste jouer ces mots, on peut rester longtemps à se poser des questions. Est-ce que le ministre a mentionné que c'est le changement de la loi, c'est pour la question de pouvoir permettre les paiements pour ce projet pilote-là, les modifications. Ce qu'on se comprend, si c'est ça que le ministre dit, clairement, bien, ça aurait pu être fait longtemps passé. Ça aurait pu être fait au mois de juin, ça aurait pu être fait au mois de mai, l'année passée. Si ça faisait des années qu'il y avait des discussions, pourquoi il aura fallu attendre au 26 octobre pour présenter le projet de loi? Si c'est une question de paiement, là. Bon, je n'ai pas besoin de réponse sur celle-là, là. Ça porte beaucoup d'interrogations supplémentaires. Est-ce que le ministre peut nous dire si, depuis l'ouverture de la clinique, donc les opérations ont débuté, est-ce que des paiements ont eu lieu à la clinique?
Thanks again, and again, for clarification purposes, the contracts between Vitality and the doctor, that's where the transaction takes place. Doesn't take place between the minister or the Department of Health and the doctor. Interesting, we were talking about some numbers about number of surgeries, and between September 30th and October 30th, when the number of people on the wait list was 6,936, and as of October, 1 month later, it was 6,655. So a significant reduction in the number of people on the wait list, and the number of people waiting greater than a year. On September 30th, it was 578, and October 30th, if it was these people waiting greater than a year, were 538. So obviously the clinic's up and running, and the contract between Vitality and the doctor is occurring. And again, when we were up there making the announcement about the opening, Dr. Giovanni was very, very pleased to be able to move forward on this, as were a number of members of the community, including some of the MLAs across the floor, that were very, very happy to see the clinic open and moving forward.
Merci, Monsieur le Président. En date du 30 septembre, question au ministre, en date du 30 septembre 2022, est-ce que Vitalité avait l'autorité, est-ce que c'était Vitalité qui avait l'autorité d'utiliser le Medicare pour payer la clinique en question?
And again, Mr. Speaker, I'm not sure what the member is trying to land on or what point he's trying to make. You know, this legislation is basically catching up with the anticipation or again, procedures are occurring in anticipation of this legislation. But again, if there's something nefarious that the member opposite is trying to land on, why don't just directly say it, and we can address that. But again, this is a contract between Vitality and the doctor, and you know, some of that information or some of the concerns that the member has opposite might be addressed in a different venue. But from a standpoint of results, that's what this government is doing. From the standpoint of making bold action and getting the results that make it better for the people in the province of New Brunswick, you know, those are the steps we're taking. And again, if the member is trying to make some type of accusation here of wrongdoing, why doesn't he just come out and state it clearly, and we'll address that issue.
Merci, Monsieur le Président. Je pense que le ministre a juste besoin de répondre clairement à la réponse et au lieu de tourner autour du pot, ça va être un peu plus simple. Donc, je repose la question différemment. Est-ce qu'actuellement, parce que le projet de loi fait la modification de la loi sur le paiement des services médicaux et règlement pris en vertu de la loi sur les paiements des services médicaux. En date du 30 septembre 2022, est-ce que ces deux éléments-là permettaient à Vitalité de pouvoir, ou permettaient au Medicare de payer la clinique privée? Je comprends l'histoire de l'entente, de contrat, là. Mais c'est qui paye? C'est qui permet que le Medicare soit utilisé? Est-ce que c'est Vitalité ou c'est le ministère de la Santé? Donc, une question facile. En date du 30 septembre, est-ce qu'il était possible d'utiliser le Medicare pour rembourser les services de la clinique privée? C'est pas compliqué. Si le ministre veut juste dire, si c'est oui, qu'il dise oui. Puis là, je vais y poser la question après ça, bien, pourquoi? C'est quoi? Pourquoi qu'on a attendu aussi longtemps? Puis il nous expliquera pourquoi qu'on a attendu aussi longtemps avant de présenter ces modifications pour les paiements. C'est simple, il donnera la réponse, puis on va passer à autre chose.
Thanks very much. And again, just trying to clarify for the member opposite, look, and I know he's trying to land on something that could be nefarious. I took over July 15th as Minister of Health, and one of the tasks I was given was to remove the barriers to make sure that that patients could get quick good service as soon as possible. One of the issues on the desk was this clinic, the cataract clinic. So I said, yeah, let's go forward. And again, knowing that there's some legislation that needs to catch up, we wanted to make sure that people were getting that service as soon as possible. So the dates may not have lined up specifically to the liking of the member across the way, but in anticipation of the legislation and approval, things went forward, which again provided service, excellent service to a number of people that have been waiting over a year to get their eyes operated on so they could see better. Anyways, if the member wants to take offense to that, fair enough. But again, trying to figure out exactly what the point's trying to be made here. More than happy to beat it around some more.
Merci, Monsieur le Président. Au ministre, je repose une simple question. Donc, clairement, il veut que ça dure. Est-ce que les modifications au projet de loi, 2 sections, là, loi sur le paiement des services médicaux et règlement pris en vertu de la loi sur les paiements des services médicaux, si le projet de loi ne passe pas, est-ce que le Medicare pourra quand même être utilisé afin de payer des services à l'intérieur de la clinique privée dans un projet pilote qu'on parle actuellement? Oui ou non?
There's an expression that comes to my mind here, and I'm not sure if it's translatable, but where we say, no harm, no foul, where no one was actually, no one was aggrieved by the actions and the timing. In fact, people were assisted, people were helped. No one was denied access to medical surgery. Nobody was overcharged, undercharged, or charged double. So actually moving forward on this, having the legislation catch up, again, those procedures are something that have occurred in the past where a policy or a procedure is changed in anticipation of decisions that are going forward. So again, I hope that translates properly for the member opposite, that there's been no harm done, there's no victim here, there's no one that's been aggrieved. So I'm not sure what picture he is trying to paint here, but again, that's I guess the only response I have for the member across. wanted to anxiously reduce the wait times, because that was a need that was itemized for the people in the province of New Brunswick. And again, when I was tasked with moving the barriers, some of the barriers was, again, to give Dr. Giovanti the go-ahead to start. And again, the timing may be an issue for the member opposite, but again, the precedent has been set in other periods of time. So again, no harm, no foul.
Merci, Monsieur le Président. Le ministre continue à pas vouloir répondre. Est-ce que, Monsieur le Président, le ministre pourrait nous indiquer, est-ce que le contrat actuel entre Vitalité et la clinique privée est en contravention, actuellement, là, est en contravention avec la loi sur le paiement des services médicaux et ou les règlements pris en vertu de la loi sur les paiements des services médicaux? Oui ou non?
The contract is not a contravention of the Medical Payment Act, nor the RHA Act.
OK. Donc, merci, Monsieur le Président, pour la réponse du ministre. Est-ce que le contrat en date du 30 septembre 2022 est en contravention des deux éléments que j'ai mentionnés? Oui ou non?
Yeah, and again, just trying to clarify, member opposite seems to be very litigious in his questions here today, and if he's got a legal advice or a legal opinion that he wants to put forward to the floor so that we could examine, I would ask him if he would table that so that we could have a good discussion, so he's not, we're not just dancing around and trying to figure out, timing on something that may, well, actually, again, in alluding to the contract, it doesn't, there's no, there's no wrongdoing here, if that's what the member's trying to get to. We're helping people, we're moving healthcare forward, and if the member wants to make some accusations or charges, why doesn't he just come out and say them? Or if there's a legal opinion that he has, more than happy to have a look at that. It reminds me of the time when Brian Gallant was over here as Premier and moved forward with the increasing the HST on everything in the province of New Brunswick, and the legislation caught up a couple of weeks later, and there seemed to be no issue with all the Liberal members at the time. you know, and you can go back on YouTube, and Brian Gallant said right up that he's going to start collecting that money from all the residents of the province of New Brunswick, even though the legislation wasn't passed. And that was the precedent that I alluded to earlier. And again, if the member opposite keeps pushing, you know, I'm going to call out what happened. You know, the Premier of the day, the Liberal leader of the day, advised by the present leader of the day, went forward and started collecting HST before the legislation caught up. That's what happened. It's historical. It's in Hansard. It's on YouTube. The member can check. So the precedent has been set that sometimes legislation catches up and things occur. Now, it's not exactly the same. It's not exactly the same because what we're doing with the clinic, and again, the legislation is such that allows for Vitality to pay doctors for procedures. Procedures started occurring. The doctor was paid. And again, the legislation here is now caught up. And again, if there's some accusation that the member wants to make, clearly make it. But it may be that he would also be making that accusation against his former Premier and the people that were advising the Premier at the time.
Merci, Monsieur le Président. La beauté, c'est qu'actuellement, je comprends que c'est le ministre de la Santé lui-même qui danse. On va le laisser danser encore un petit bout parce qu'on dirait qu'il se plaît à danser. Donc, si le ministre m'a répondu tantôt qu'actuellement, en date d'aujourd'hui, le contrat entre Vitalité et la clinique privée n'est pas en contravention avec la loi sur le paiement des services médicaux et ou les règlements pris en vertu de la loi sur les paiements des services médicaux. Il m'a répondu que ça ne l'était pas en date d'aujourd'hui. Donc, est-ce que le ministre peut juste nous dire, en date du 30 septembre, la logique est avant le dépôt du projet de loi, est-ce que le contrat est en contravention, oui ou non? Je promets au ministre que s'il me donne une réponse oui ou non, je passe à autre chose. Donc, si aujourd'hui, elle ne l'est pas, mais en date du 30 septembre, elle l'était, qu'ils disent. Alors, je vais passer à autre chose. On va peut-être, parce que ça commence à être tannant de le voir danser actuellement.
Mr. Chair, to you, I apologize to the member across the way if it's, if I've caused some confusion here on the whole topic. And it seems that, again, the way he's questioning, there must be a legal opinion or a legal document that he has in his possession. So I'd ask the member if he wants to table that legal opinion, send it over, and we will look at the nuances of that opinion. Because again, I'm not sure where the member is trying to land or where he's trying to point the finger. If he's saying that we jumped the gun and started without the proper authorization. The authorization was always there to pay Dr. Giovanni for the services that were rendered. That's very clear. He was getting paid the day before. He was getting paid the day he started in his clinic. So again, there was nothing nefarious that occurred that would provide the member opposite with some information that would, again, and I guess I look at the outcome, where are we, where is the member trying to land? Does he want Dr. Giovanni to stop the operations or can't undo the operations? Does he want us to claw the money back if there was any money that changed hands based on the contract that was alluded to? And if the member opposite is just trying to, create some political upheaval or trying to embarrass the minister. I get it, that's his job. Again, what we're trying to do is, again, provide good care for the people of New Brunswick, provide care that were on the waiting list, provide care for people that were on the waiting list more than a year. And so again, if the member opposite takes offense to that the dates didn't line up exactly, again, that's unfortunate that he's not pleased with that, but what I'm pleased about is that people now are getting care in a clinical setting in the northern part of the province, in the Bathurst region, which again has cleared up some time in the waiting room for other operations to occur. So people again are happy that their hip replacements are moving forward, their knee replacements are moving forward, that they're getting their cataract services and can see much better than before. So again, if the member's trying to make that accusation based on a legal opinion that he has, more than happy to look at that legal opinion and take the question under advisement, get back to him, and have our legal department look at that contract between Vitalite and Dr. Giovanni. But again, I'm just trying to understand what the member opposite's goal is here. What the outcome is he looking to accomplish? Is it just to embarrass the government, or is it to again claw back the money from Dr. Giovanni, or what is it to do? Really appreciate the clarification on what the ultimate goal is that the member opposite is trying to accomplish here today. Because I know the goal that we're trying to accomplish is to, again, making sure that people get the services that they need in a very quick and expedient manner.
Merci, Monsieur le Président. Au ministre, la question au ministre, ou peut-être un commentaire, Monsieur le Président. Le ministre de la Santé n'a pas besoin de moi ou d'un député d'opposition pour embêter son gouvernement. Il est bon lui-même. Donc, il a juste à répondre clairement aux questions. Et puis, c'en est un petit peu... je serais embarrassé, moi, être à sa place, de laisser transparaître comme si je suis contre le docteur Giovanni ou que je suis contre que les patients puissent avoir des opérations de compléter, que je suis contre que les listes d'attente diminuent. Je pense que j'aurais honte à la place du ministre de continuer à répéter ce genre d'affirmation-là. Mais je pense que aussi j'aurais honte d'être à sa place et de ne pas vouloir répondre clairement aux réponses. C'est peut-être en bout de ligne, Monsieur le Président, le ministre qui a peut-être un avis légal qui lui dit de faire attention à ce qu'il répond parce qu'il y a peut-être contravention à la loi actuellement. Donc, je vais lancer cette question-là au ministre. Est-ce que actuellement, le ministre a un avis légal qui indique que, au mois de septembre, est-ce que le ministre a un avis légal qui dit qu'il y aura peut-être contravention? On va laisser le ministre répondre.
Mr. Chair, to you in general, any legislation that's passed has a legal opinion. It's a memorandum to Executive Council, and again, some of the members across the way used to be in cabinet under the Gallant government, and again, the member opposite should know that anything that moves forward in legislation has a legal opinion. So this particular act has a legal opinion that, again, allows it to move forward or is part of the process moving forward. And Cabinet makes the decision, again, that policy can be implemented right away, and it doesn't have to wait for legislation here to pass on the floor. A lot of times actions occur in anticipation of those those actions. So, you know, again, the member opposite is more than happy just to continue talking about this all afternoon, but I'm sure there's some other items that might be of interest to him. But we can go back and forth on this, no problem. I asked him if he had a legal opinion. He didn't give one. He didn't present one. Yes, I have one. It's part of cabinet documents. And again, it allows this legislation to go forward. And that's part of the decision that weighed into cabinet making this good legislation land on the floor here today. And if the member's not against it, he says he's not against any of the things here, why don't we just pass it now and move forward?
Merci, Monsieur le Président. Ce que je comprends aujourd'hui, ce que le ministre ne veut pas dire, c'est que depuis que le cabinet a approuvé la présentation du projet de loi, ça aurait été simple à dire. J'en reviens tout simplement pas. Depuis que le ministre comme il a indiqué, depuis que le cabinet a approuvé que le projet de loi puisse être présenté dans la Chambre, ces mesures-là sont applicables. Il y avait juste besoin de répondre à ça. C'est ça qu'il vient juste de dire. Qui veut dire qu'au mois de septembre, ce n'était pas applicable si le cabinet n'avait pas encore fait ses démarches. Mais compte tenu, Monsieur le Président, que le ministre a indiqué qu'il y avait un avis légal par rapport au projet de loi, est-ce qu'il peut déposer l'avis légal à la table du greffier?
The member opposite should know that any advice given to cabinet is confidential. But he's trying to make some political points here, and I get it. You know, I appreciate what he's trying to do, and good on him. But again, when the patient care comes first, you know, that's what we're trying to do. The member opposite, he says he agrees with everything. If his dates aren't lining up, well, again, this is something that I'm just surprised that he would be looking at this in some way nefariously, because everything moves forward, you know, decisions are made, there was a significant amount of investment made, and again, his members supported it and there was no issue at all. So, you know, chapeau to the member opposite trying to make an issue out of something, again, that is showing a great benefit for the people in the northern part of New Brunswick. So anyways, legal opinions make up part of the memorandum to Executive Council that are confidential, and I know the member opposite sends significant number of RTIs to the department and takes up a lot of time and resources of the department, but we're happy to do that because that's part of the legislation as well. And again, to get into some of those nuances of a contract between the RHA and a third party is something that again, the member, I'm sure, would RTI in the future, as he probably would RTI some of the questions that are being asked here today.
Bon, merci, Monsieur le Président. C'est clair que ça chatouille le ministre actuel, ça chatouille l'ensemble des ministres avant lui. En fait, c'est le troisième ministre de la Santé depuis 2018. Ça les chatouille pas à peu près quand il y a des demandes d'accès à l'information. C'est comme si, c'est simple, hein? Moi j'ai toujours dit, Monsieur le Président, si le gouvernement était transparent et fournissait, répondait clairement, facilement aux questions qu'on leur pose, on n'aurait pas besoin de faire des demandes d'accès à l'information. Je sais que le ministre, ça le chatouille. Puis sa prédécesseur, ça la chatouillait. Puis le prédécesseur d'avant, ça le chatouillait aussi. À cause que c'est une tendance de ne pas vouloir répondre clairement aux questions. Mais, Monsieur le Président, je vais passer à une autre question. Mais juste avant, je vais faire un commentaire au ministre. Quand le ministre nous dit que les avis légaux au cabinet sont confidentiels, il va falloir poser la question à quelqu'un d'autre parce qu'on va me dire que je ne suis pas par rapport au projet de loi. Sauf que hier, il a sorti un avis légal dans les médias concernant la considération du gouvernement d'avoir un contrat d'autobus privé, autobus scolaire privé. C'est un avis légal, ça. J'aimerais vraiment comprendre comment ça qu'il y a certains types d'avis légaux au cabinet qui peuvent sortir publics, puis il y a d'autres avis légaux au cabinet qui ne peuvent pas sortir public. Mais bon, c'est un commentaire en passant, je n'ai pas besoin de réponse. Je pense que ça démontre quand même que quand ça fait l'affaire du gouvernement, on dit que c'est confidentiel, mais la réalité, bien, dans d'autres cas, tout d'un coup, on s'aperçoit que c'est dans les médias, puis on peut se poser des questions. À cette heure, je vais aller à une question qui a quand même un rapport direct parce qu'on parle des régies. Est-ce que le ministre de la Santé peut nous dire si les régies sont assujetties à la loi sur les langues officielles?
Quick answer, yes. Oui. La réponse, c'est oui. And Bill 3, I'm not sure how that affects the Official Languages Act.
Bon, merci beaucoup, Monsieur le Président. C'est que la raison que je veux juste être certain de comprendre, c'est que la régie, parce que les modifications, il y a des modifications à la loi, là, mais la régie, dans ce cas ici, étire son bras. Hein? Elle prend son bras, là, puis elle étire un contrat à l'extérieur de ses murs, comme le ministre le dit si bien, là, je pense que c'est le cement and mortar, ou en tout cas, je vais le laisser, brick and mortar, je pense que le ministre utilisait comme terminologie, mais la régie étire son bras de sa responsabilité. Le ministre vient de dire qu'il a une responsabilité de respecter la loi sur les langues officielles. Est-ce que ce contrat-là a la même responsabilité?
La réponse, c'est la même, Monsieur le Président, c'est oui.
Parfait. Merci beaucoup, Monsieur le ministre. Vous voyez, une simple question, une réponse simple, facile. Quand je dis simple, c'est en termes rapides. Donc, on peut maintenant passer à une autre question. Puis je pense que si on continue de même, on va peut-être pouvoir accélérer. Est-ce que le ministre peut nous dire si les modifications actuellement, parce qu'on parle de diminuer les temps d'attente, augmenter les chirurgies, on parle cataracte d'un côté, de l'autre côté, au niveau des genoux et des hanches. Est-ce que le ministre peut nous dire si, dans tout ça ici, là, l'augmentation des opérations du genou, des genoux, hanches et celle de la cataracte, l'argent que le fédéral, le 41 millions que le fédéral a donné, sera utilisé pour un et ou l'autre de ces types de chirurgie à Bathurst?
Thank you very much. And that's a good question. It's interesting. It's been batted around here a little bit over the last little while. When we receive money, a budget allocation during the budget process, I'm not thinking capital, which is coming up here shortly, but the operating, again, which runs April 1 to March 31st. Whether it's part of the Canadian Health Transfer, or specific for a particular project, it goes into a global budget. And out of that global budget, we provide all the various services. So in this particular case about the clinic and Vitality, they've worked together to identify some key performance indicators. And some of those indicators will include the number of surgeries performed monthly, annually, total number of surgeries, number of complications or side effects, waiting time by priority for both completed surgeries and pending cases, and again, meeting some of the provincial timeline targets, and the effects on the wait times and targets of other surgical specialties at the Chaleur Regional Hospital. So that alluded to some of the comments that were made earlier. And from a standpoint of the money and 41 million being spent, as member opposite should know, the update that was put on the floor by the Minister of Finance the other day, it's projected that healthcare will be over budget. Basically, there's not going to be any money left on the table. So we're about halfway through the year. The last update was second quarter update, and we're already projecting to be over quite substantially. So the 41 million that the opposition continues to allude to that hasn't been spent, Mr. Speaker, that's being spent, and it will be spent. And you know what, we are actually asking the federal government for additional contributions through the Canadian health transfer. And you know, originally when the federal government decided to give the province the authority to take care and manage their healthcare systems, they said they'd be there for 50-50. 50% of the money comes from the feds, 50% from the province. Well, that percentage has now dropped down to 22%. And that's why the premiers of across Canada we're asking Justin Trudeau for a meeting to increase that contribution, not back to the 50% that was the original mandate, but even up to 35%. And that, again, is part of to keep the sustainability long-term for the province, the various provinces, because they're moving forward with recruitment, they're moving forward with medical schools. We here in New Brunswick are adding medical schools. So the money that is received from the feds, regardless of unconditional or not, for the health department, it will be spent. Our projections will be over budget and may need a supplementary estimate to be put on the table. And hopefully the members opposite would support that supplementary estimate, which would include the 41 million they keep alluding to.
Bon, merci, Monsieur le Président. J'écoutais le ministre, puis je me suis dit, OK, bien, il dit que tout l'argent est dépensé, mais la réalité, au cours des dernières années, tout l'argent n'a pas été dépensé dans les budgets du ministère de la Santé. Puis ça, on ne parlera pas de l'argent du fédéral. Hein? On ne parlera pas de ce qui est arrivé du fédéral. Là, on parle du 41 millions. Et bon, puis je voudrais quand même porter un commentaire intéressant au ministre. Je me souviendrai toujours quand il y avait les discussions concernant l'importance, quand il y avait les discussions de l'importance de l'ajout du gouvernement fédéral, d'argent du gouvernement fédéral. Je me souviens, je pense que c'est le chef de cabinet du premier ministre, puis le ministre pourra certainement nous faire la confirmation, mais je pense que c'était le chef de cabinet du premier ministre du Nouveau-Brunswick qui avait fait un petit message sur Twitter disant que pour solutionner le problème de santé, tout n'était pas une question d'argent. Donc, en tout cas, ça fait bizarre avec les commentaires du ministre. Je ne sais pas c'était quoi l'objectif du chef de cabinet à ce moment-là, mais bon, il l'a mentionné. Donc, le ministre parle d'un côté, puis le chef de cabinet du premier ministre dit autre chose de l'autre bord. Bon. Est-ce que le ministre peut nous dire si, avec le projet de loi numéro 3, est-ce qu'on s'attarde seulement à ce projet pilote-là, de cette clinique privée-là, ou est-ce que ça va faire en sorte que d'autres cliniques privées pourraient être ouvertes pour d'autres services sans avoir besoin de refaire un amendement à la loi ou aux lois?
Thank you very much, Mr. Speaker. This particular bill is specific to the clinic in Bathurst. And again, it does open the door for other opportunities. And again, I know that there's some other cataract clinics that are interested in getting on board too. And again, it's always evaluated, and that's why I mentioned the number of evaluations that are occurring there in order to make sure that there's no unintended consequences. And again, many proposals come forward by various ways to the RHAs or to the Department of Health, and they're always evaluated based on need, patient need in the province, and wait lists and wait times and whatever. But again, the Acadia Bathurst Ophthalmology Clinic project is an example of an innovative solution to getting things done here in the province of New Brunswick. And this particular bill has that specific clinic in mind, and it may open the door for some other opportunities in the future to help the people in New Brunswick receive additional care for whatever the needs are.
Merci, Monsieur le Président. Est-ce que le ministre peut nous dire si la clinique, cette clinique privée-là aura le droit de faire des tests, qu'on appelle des privilèges, là, avec les réseaux de santé? Est-ce qu'ils pourront faire des tests, peu importe là, lesquels, là? Est-ce qu'en fait, ils pourront utiliser des privilèges au réseau de santé Vitalité?
Yeah, the arrangements between the hospital and the RHA and the physician, it continues. The physician has privileges in the hospital. So again, if I understand the question correctly, those privileges continue as they were beforehand.
Si, Monsieur le Président, au ministre, c'est juste une question de clarification, là. Est-ce que le médecin, docteur, ou le chirurgien, docteur Giovanni, va continuer à exercer des services dans l'hôpital Chaleur, ou ça va être, il va seulement faire les services de chirurgie à l'intérieur de sa clinique?
Mr. Chair, through you to the member opposite, I can't imagine why Dr. Giovanni would want to, well, I guess I could, if there was a complex surgery, something that was not just the routine, I mean, cataract surgery, the technology on that has dramatically increased the success and the speed at which that's done. It's interesting. So I guess if I understand the question correctly, or the outcome that the member opposite is looking for. The doctor certainly has privileges at the hospital, and if there's a complex case that he thinks should be done there with some of the other backup or other surgeries, you know, if there's complications or whatnot, that's his decision. But looking at the clinic, I mean, it's impressive. And again, he can ask the two members from his side who were there in support of it, just how professional it is. And again, talking to some of the patients, we were there at 9 o'clock, and I think there were 5 patients that had already been through, and that's how it was Bathurst West Nipisiguit and Bathurst West Bareford, if you're wondering. Anyways, so the clinic, it's a immaculate clinic, and the folks had gone through, I think, about 4 or 5, even before we were there at 9 o'clock. And anyways, they were very pleased with the surgery. We talked to them, and it was very impressive. So I would only assume, again, the business plan and the agreement allows for the doctor to go back to the hospital, but again, the hospital wants to use that space for hip and knee and cancer surgeries. So they were quite excited to have those couple of days freed up that the cataract surgeries weren't being done. So I guess that's part of the business plan that vitality, and the clinic will continue to monitor to make sure that there aren't any unintentional consequences, but certainly the outcomes that we saw on that day and the ones that are being reported to us have been very positive.
Merci, Monsieur le Président. Et au ministre, j'en suis convaincu que la technologie est très avancée. Je n'ai pas de doute à ce niveau-là. Peut-être la prochaine fois, le ministre pourrait peut-être juste avoir l'obligeance. Je sais qu'il n'arrête pas de mentionner certains de mes collègues, là, puis il a l'air à se faire un malin plaisir de ça, mais j'espère que la prochaine fois qu'il les invite personnellement, au lieu qu'ils apprennent la nouvelle dans les médias, ça serait probablement intéressant, parce que je pense que le ministre prend du crédit énormément là-dessus, mais il ne semble pas que le ministre ou le ministère a eu l'obligeance d'inviter ses collègues de l'Assemblée législative à l'annonce. En tout cas, c'est peut-être juste un petit reminder pour les prochaines fois, là. Donc, s'il veut vraiment utiliser le crédit, bien, qu'il fasse ses invitations aussi. J'aimerais poser, par rapport aux questions ou aux commentaires ou la dernière réponse du ministre, la Régie de santé et vitalité, bien, en passant, je voudrais juste dire au ministre une petite phrase intéressante. Sa prédécesseur, pas longtemps passé, je vais attendre que le ministre puisse bien entendre ce que je dis là. Peut-être juste pour le ministre, là, à titre d'information, sa prédécesseur qui siège encore avec lui, qui est maintenant ministre du Développement social, on sait qu'il y a eu un changement juste de même au mois de juillet, si je me souviens bien, m'avait déjà dit, quand j'étais là, puis quand je lui posais des questions à sa prédécesseur, je parlais de cliniques privées, et puis sa prédécesseur a été vite à me dire que j'étais contre le système public parce que je parlais de cliniques privées. Je vais toujours me souvenir de ça, là. Puis aujourd'hui, bien, le ministre de la Santé il parle de cliniques privées. Et puis, depuis tantôt, il essaye de dire de temps en temps, bien, je suis contre ci, je suis contre ça, je suis contre les patients. Bon, je vais quand même mettre ça clair. C'était quand même ironique, puis je me souviens encore de cette phrase-là de la part de sa collègue. Ça aurait été le fun que ce soit elle encore la ministre de la Santé, quasiment, parce que j'aurais pu juste lui rappeler ses paroles, mais je n'ai pas cette chance-là. Ou bien donc les citoyens ont peut-être une meilleure chance aujourd'hui avec le nouveau ministre de la Santé. On verra. La raison que je posais la question tantôt concernant les privilèges, Monsieur le Président, au ministre, c'est que Vitalité a comme toujours donné comme réponse que si un médecin veut ou peut avoir des privilèges, c'est à cause qu'il donne du temps à l'intérieur du réseau de santé, dans le réseau de santé, pas à l'extérieur, pas dans son cabinet privé, là, parce qu'on sait que les médecins ont leur bureau. C'est à eux le bureau, là, c'est pas à la Régie ou au ministère de la Santé. Donc, le système de privilèges est, tu donnes des heures à l'intérieur de l'hôpital, et puis, quand tu es dans ton bureau, on te permet d'utiliser ton privilège pour faire des tests de santé, rayons X, et ainsi de suite. C'était ça la réponse de la Régie, puis c'était quasiment ça aussi la réponse des anciens ministres dans le passé. Puis là, aujourd'hui, le ministre nous dit, bien, à moins de circonstances comme vraiment situation critique, dans ce temps-là, le chirurgien, j'aime pas trop prendre l'exemple du chirurgien, mais c'est le cas, c'est l'exemple du cas là, que je fais là. La clinique aura l'opportunité de faire ses privilèges, ses tests à l'intérieur du système de santé, donc dans l'hôpital de Bathurst. Le ministre a certainement déjà entendu mes questions concernant des infirmières praticiennes opérant en clinique privée dans la zone 4. Et puis aussi un cas d'infirmière praticienne opérant en clinique privée dans le réseau de santé Horizon. Dans le réseau de santé Horizon, cet exemple-là fait que, puis vous allez voir le parallèle que je vais faire avec le projet de loi, n'inquiétez-vous pas, Monsieur le Président. Dans le cas de l'infirmière praticienne dans Horizon, même s'il n'y a pas de temps de donner à l'intérieur du centre hospitalier, les privilèges sont permis, sont faits. Donc, les tests sont faits. tests de sang, rayons X si nécessaire, et ainsi de suite. Mais quand on arrive dans la zone 4, puis c'est encore le cas aujourd'hui, des cas d'infirmières praticiennes en clinique privée, dans leur cas à eux, c'est encore interdit de pouvoir avoir des privilèges faits à l'hôpital, prenons l'hôpital régional d'Edmundston à titre d'exemple. Puis la raison pourquoi on mentionnait ça, pourquoi que les régies, le ministère et les ministres du temps mentionnaient ça, c'était toujours la même chose. Parce que le professionnel de la santé ne donnait pas d'heures de temps de travail à l'intérieur de l'hôpital. Donc, ma question, compte tenu que là, le ministre a présenté le projet de loi le 26 octobre pour cette clinique-là en particulier à Bathurst, qui est une clinique privée, puis que maintenant on sait que cette clinique-là pourra faire ses privilèges à l'hôpital, puis ne sera pas bloquée, même s'il n'y a pas de temps de donner à l'intérieur du centre hospitalier, est-ce qu'on peut s'attendre dans un délai raisonnable, voire une modification qui fera en sorte que des cliniques privées d'infirmières praticiennes puissent aussi faire des demandes de privilèges dans les hôpitaux pour leurs patients? Puis la raison pourquoi que je pose la question, Monsieur le Président, c'est si là, on avait suffisamment de médecins ou de professionnels de santé primaire, prenons des médecins, qu'on avait assez que l'ensemble des citoyens du Nouveau-Brunswick avaient un médecin de famille, peut-être qu'on n'aurait pas cette discussion-là. Mais actuellement, les dernières données du gouvernement, c'était 70 ou 73 000 citoyens qui n'avaient pas de médecin de famille au Nouveau-Brunswick. Mais le réseau de santé et vitalité a allé au mois de septembre, puis le ministre a certainement les données, c'est 19 de la population de la zone 4 qui n'ont pas de médecin de famille. Donc, 19 des citoyens de la zone 4 qui n'ont pas de médecin de famille. Donc, il y a des infirmières praticiennes en clinique privée qui offrent un service parce que les réseaux et le ministère de la Santé n'est pas en mesure de pouvoir donner suffisamment de médecins de famille pour que l'ensemble des citoyens puissent avoir accès à un médecin de famille. Donc, compte tenu qu'on a ce projet de loi-là aujourd'hui pour une clinique privée, et puis que cette clinique privée-là a des privilèges à l'hôpital, est-ce qu'on peut s'attendre que l'exemple des infirmières praticiennes, qui est aussi un service de base, en passant, Monsieur le ministre, parce que c'est pour combler un manque de médecins de famille dans une région, puis ça pourrait être bien ailleurs, est-ce que vous vous attendez dans un délai très près, Monsieur le ministre, de corriger cette injustice-là, puis de permettre aux citoyens qui ont besoin de tests, qui ont besoin de rayons X, puissent, dans un avenir rapproché, même s'ils n'ont pas de médecin de famille, avoir une option. C'est plate, parce que l'option tout de suite, c'est qu'il faut que les gens payent pour avoir un rendez-vous, parce qu'il n'y a pas assez de médecins. C'est les options qui existent. À même titre que l'exemple de l'option pour augmenter le nombre de chirurgies de la cataracte à Bathurst ou dans la zone 6. La seule différence, c'est que là, c'est le gouvernement qui va utiliser le Medicare pour payer le chirurgien. Ce que le gouvernement et le ministère de la Santé refusent toujours aux infirmières praticiennes en clinique privée. Clinique privée, pour moi, là, une clinique privée versus une clinique privée, c'est une clinique privée. Si quelqu'un me dit que ce n'est pas des cliniques privées, bien, ils me donneront la définition. Mais est-ce que le ministre est prêt à s'engager de présenter une modification au projet de loi dans un avenir rapproché qui va corriger cette injustice?
And again, trying to accommodate the member opposite and give him short answers and precise answers. Today is not the day to have a discussion on the scope of practice of nurse practitioners in Zone 4. I mean, today we're talking about one specific clinic, which again allows that privilege and the opportunity of those privileges between a clinic and an RHA to start as a pilot project. Again, making sure there's no unintentional consequences and that it achieves the goal that we set out, which was reducing those wait times. We put a 24-month period on this. This particular bill allows that relationship between the clinic of Dr. Giovanni and the Vitality and the Bathurst Hospital to occur, which again can be positive, but to unravel the scope of practice and the comparison between the two, that's an interesting topic. And again, but for today's purpose, in examining Bill number 3, I think I'd ask the member if we would concentrate on the particular point of the day, which is Bill 3, which is in Zone 6. But again, we're well aware of some of the issues and concerns that the member brought up, and we know that the work is not done, but this is one step in that direction. We know that there's other clinics that may want to be involved, and again, I'm sure that they will make those proposals known to us in due course. And again, every opportunity is evaluated either through the RHA or through the health department, the various components of it. And when it comes again to scope of practice, that's always something that is an interesting discussion. And just to go down that rabbit hole a little bit, expanding the pharmacies, the opportunity for pharmacists to evaluate and prescribe certain medications or renew certain medications. That again is another step in the right direction in providing that primary care. So there's a whole conversation I think that is possibly or that is definitely outside the scope of this particular bill here today, but this is one of the pieces directly specifically to the relationship between the RHA Vitality and this particular clinic, and it allows for those privileges to go and occur between the said parties.
Merci, Monsieur le Président. Au ministre, en passant, je ne parlais pas du scope of practice. Absolument pas. Je ne sais pas d'où qui a pris ça. Parce que les infirmières praticiennes qui travaillent dans des centres communautaires, des centres de santé communautaires, à titre d'exemple, ont ces privilèges-là. Donc, c'est pas, il n'y a pas de question de scope of practice dans ce dossier-ci, en lien avec ma question. Ma question était que le projet de loi numéro 3 ouvre l'espace aux cliniques privées. Donc, on sait que le ministre a voulu se limiter à une clinique actuellement. Ma question est, est-ce que le ministre s'engage à évaluer la possibilité afin que des infirmières praticiennes en clinique privée, puis, en fait de compte, c'est pour régulariser aussi le cas dans le réseau Horizon, là. C'est une question de régulariser, là. Donc, est-ce que le ministre est prêt à s'engager à débuter tout de moins cette démarche-là pour qu'on puisse trouver des solutions, que ce soit privilèges, permettre les privilèges, et ou que le Medicare puisse payer pour les services rendus lorsqu'il y a des rendez-vous. Donc, si le ministre dit qu'il est prêt à s'engager à regarder ces options-là, des privilèges et ou permettre au Medicare de payer pour les rendez-vous, je vais être satisfait de la réponse.
Thank you very much, Mr. Speaker. And again, looking to be concise in my answer, and again, when we talk about scope of practice, a nurse practitioner is doing certain things, and again, depending on the setting of that particular practice or moving forward with their scope of practice, if it's in a public health clinic, then that's one situation. If it's in a private clinic, that's another situation. What Bill 3 does here today is look at a specific relationship between a Vitality and a cataract clinic. So that's very specific. The intention wasn't to throw the doors open and just let any private clinic operate and be covered by Medicare. And I know that's where the Leader of the Opposition was quite adamant that they didn't support private clinics. or privatization. Again, my wording might be a little bit different than the verbatim of the leader. But again, when we look at this particular bill, Bill number 3, which we're discussing today, it's based on a pilot project, and that pilot project will be evaluated with various goals and outcomes, and that's, I think, important to do, because you know, again, making sure that the objectives are being realized and the outcomes are being realized when you go into a relationship like that. I think that's the important thing, and again, making sure that that those particular items are being paid for by Medicare. Again, make sure that there's not a two-tier healthcare system, which I think some people allude to. But any other clinics that are looking to have some type of an arrangement like that, again, those proposals will be evaluated. They'll be looked at in the future as time goes on, and so whether it's an MP or a group of MD, NP, or whatever type of clinic, but we continue to look and evaluate at again, how can we provide that primary care as best as possible, on time, at the time people need it. And we could go on discussing that at length, but the Bill 3, the particular one, we'll stick to that today. Appreciate that.
Merci, Monsieur le Président. J'espère que le ministre va continuer à travailler avec son ministère pour trouver des solutions aux problèmes. Donc, je pense que c'est le ministre qui a ouvert la porte avec les modifications au projet de loi, avec une première clinique privée pour être payée par le Medicare et qui permet en même temps à cette clinique privée-là de pouvoir avoir accès aux privilèges, ce que d'autres cliniques privées n'ont pas accès actuellement pour ceux qui offrent des soins de santé primaire. Parlons pas de soins esthétiques, là, on parle de soins de santé primaire. Bon. On sait que ce projet pilote-là, c'est un projet. Puis, à un moment donné, il va peut-être falloir que le ministre nous arrive avec, si c'est un projet puis qu'il y a d'autres choses qui peuvent arriver, il faudrait peut-être que le ministre, à un moment donné, nous arrive avec un projet de loi, non pas à la pièce, mais un projet de loi qui pourrait encadrer. Je pense que l'encadrement est important dans tout ça. Pour s'assurer qu'on fait bien les choses. Mais à un moment donné, que le ministre, je ne peux pas imaginer qu'il va nous arriver avec un projet de loi individuel, ce serait comme complètement absurde. Mais compte tenu, là, on sait que ça n'a pas été fait en appel d'offres, cette démarche-là. Ça a été attribué à une clinique en particulier pour un test comme projet pilote. Est-ce que dans l'avenir, l'intention est de continuer à fonctionner comme ça, donc pas d'appel d'offres, ou bien qu'à un moment donné, il va y avoir une question d'ouverture pour que s'assurer que les appels d'offres publics soient faits. Donc, je vais laisser le ministre nous répondre, mais je pense que c'est une question importante.
Merci beaucoup pour la question. And I guess I would just, that's a big a question that can, be a long, long discussion, and that's why I was taking the time to just, fully understand what the member, or what I think the member was asking, and making sure that my response is accurate, and to have it concise as possible. Because there are many, many pieces to that puzzle, where you have agreements with physicians and the medical society about which procedures they can do in office and which procedures are not available to do in their own offices. And I mean, you can have, minor surgeries like removal of, and again, I don't want to go through the list because that may, cause people to just expand on that. But again, there's surgeries, minor surgeries or non-surgical procedures that occur within the doctor's office, and that's a negotiated thing. And there's some that will never, occur in the doctor's offices because of the complications or the possible complications that will arise. But again, this Bill number 3, which we're discussing here today, is a very specific relationship or a specific contract that occurred between Vitality and a specific clinic to do a specific service. And the idea that we're just going to open the doors and anybody can set up a private clinic, again, is not the reality or not the future that we see, because again, it's all based on needs analysis, and that needs analysis comes from the RHAs and again, looking at what the wait list is looking like, what the wait times are looking like. So for someone just to come in and open up a private clinic and expect the RHA to purchase their service is not necessarily, or is absolutely not the case. And but this legislation allows a framework to be built upon, and whether that's done in regulation or whether that's done by even ministerial approval, which again can occur. It's again a bit of a puzzle to be put together. And so in saying that, based on that needs analysis that can be done and creating the framework of a legislation, we've also engaged the services of a consultant who is looking at what that framework would go forward, and whether it is a RFP, request for proposals that allows a clinic to bid on satisfying a need after the need's been established by the regional service commissions or regional service RHAs authorities, or whether it's just done on a negotiated contract. There's many options, and again, we have unsolicited bids or unsolicited proposals all the time that are reviewed. And I know Nova Scotia just did an RFP on a particular need that they saw, and which was kind of interesting. And I'll be interested to see what kind of response occurs down there as that unfolds. So again, I know that was a bit longer and explored a number of different options, but basically to answer the question is that we continue to look at the scope of practice, the relationship between various professions, and we're not alone in this as well, because there are the various associations that have a say in who practices and what that scope of practice is, and we meet with those various associations on a regular basis and have that communication. We also work with PEDAL in again working with those associations. We're not alone in this. We have other partners as well. So so that being said, that's the response. Thanks.
Merci, Monsieur le Président. Je m'en viens vers la fin. I'm very close to my question. Maybe a last one, une dernière, puis dépendant si la réponse est claire pour l'instant. Le ministre a mentionné, Monsieur le Président, que certaines décisions peuvent se prendre, oui, par décret, de la part du cabinet, par règlement plutôt, de la part du cabinet, ou des décisions qui peuvent être prises par directement par le ministre. La question est relativement simple. Est-ce que la décision à qui les paiements du Medicare se font, est-ce que cela peut être fait soit par règlement au cabinet et ou directement par le ministre, sans avoir à changer la loi?
Yeah, once again, sorry for the delay. Again, it's just trying to fully understand the question or the intent of the question and get the proper response. So because, again, sometimes if an individual has a procedure and Medicare doesn't pay for it, they can always appeal it. And that appeal board is an appeal board made up of a number of clinical specialists or doctors. And they make the recommendation to the minister that it should be paid or it shouldn't be paid. So, and a lot of that is based on, again, clinical expertise. So the minister ultimately decides yes or no, that's being paid. So if that's sort of the intent of the question, that's going with it. And that's sort of individuals and Medicare, that relationship. In the relationship between which doctors get paid, again, depending on what procedure it is and how much they get paid, again, that's a bit of a negotiation, or that is a negotiation between medical society, the doctors, and of course the health department is there as well. So some things can fall under just normal procedural items that, again, are the practice and scope and the policy of the department. Other things are again, recommended that legislation is enacted in order to facilitate that. So, again, in absence of having a clarity on the question, but trying to make that assumption of what was asked, hopefully that will answer it.
With that, we'll take a 10-minute health break. I'd like to recognize member from Fredericton South.
Thank you, Mr. Chair, and I'll be subbing in for Megan Mitten, who was subbing in for Kevin Arsenault. Good afternoon to the Minister and the staff. Through you, Mr. Chair. So I wanted to start with some explanation from the Minister as to why this bill would open the door to establishing private facilities or private clinics for surgeries. In other words, allowing corporate-owned surgery centers rather than keeping it public as a public surgery center outside of a hospital. You know, we know Horizon and Vitalité own lots of community clinics, and they can be upgraded to offer surgeries that are appropriately delivered outside of hospitals, get the benefits that the community-based approach would provide, and yet not open the door to corporate-controlled surgery centers.
Thank you very much for the question through you, Chair. And I guess I would look at it this way. I mean, we've had fee-for-service doctors for years and years and years. And again, I mean, I'm not going into my family history, but so I'm quite familiar with how that works. So really what we're doing here is we're almost expanding the ability for fee-for-service doctors to provide service to the people of the province of New Brunswick. And again, the RHAs keep track of the wait times, the wait lists, and trying to alleviate that. Again, cataract surgeries were significantly longer than the national average, and the time on the wait list was, again, very, very long. So what Bill 3 actually does, again, enters into a pilot project, but it's really just expanding more or less the services of a fee-for-service doctor. And again, fee-for-service doctors, they either rent or build their clinics. And again, there's different types of clinics, different types of arrangements right across the province. But, and some are salaried, some are fee-for-service. So I guess in looking at the fact that fee-for-service doctors have been around for years and years and years providing services, I see this as an enhancement of the services that are allowed to be done in the clinic or office setting of a doctor. And I mean, there's some interesting dialogue on that, but again, this flexibility is serving a need that was need of the citizens of the province of New Brunswick that was identified, you know, through RHAs and some of the data they collected.
So wondering why not simply have those fee-for-service doctors and surgeons operate like they do in hospitals now, owned by the RHAs, operate in community health centers modified appropriately to provide those surgeries in community health centers owned by the RHAs.
Well, that, and again, that's a discussion we could take a considerable amount of time on. But, you know, because when we think of the stress right now within the RHAs in trying to provide staff to provide the services for the people that are presenting themselves, whether it's the emergency room or wherever within the hospital, and looking for that facility. So, you know, so if you wait for the RHAs with, you know, to increase their overhead or hire the staff or find the staff, recruit the staff, and, you know, put them in these clinics. Now, some of that is occurring. We had a tour of the clinic down here, Dr. Davidson, which is an interesting clinic because it does work with UNB, with the RHA, with the and with Dr. Davidson. It's quite interesting the dynamic that's going on there. And they have, you know, walk-in services, they have LPNs and all kinds of things. So the idea of these clinics is occurring, but this can, again, ramp up some of the, again, satisfy some of the needs. So we're exploring all different kinds of options. And again, Bill 3 here today allows us to move forward with this particular option. And again, we are open to other proposals. And again, always based on need. What are the needs of the citizens in the various zones or the various areas, and how can they be best met? Again, it's a critical time in healthcare, and making these decisions to alleviate some of those wait times and wait lines is again taking some interesting ideas, and it's good to see this particular one moving forward, in my opinion.
Mr. Chair, I'm wondering if the minister heard Professor Claire Johnson's interview on Information Morning on Monday. She's an assistant professor in health management with extensive expertise in public administration as well as health sciences at the University of Moncton.
I did not hear it, but I read the transcript.
I didn't hear that last comment. He didn't hear the interview, but he read the transcript?
That is correct.
That's correct. So one of the things that Professor Johnson has done is looked at the differences between those surgery centers that or community-based clinics that offer surgeries that are public versus private. And she talked about a private one in Quebec and the problems that develop there versus a public one in London, Ontario, which didn't have the same problems. The one in Quebec, she talked about the costs, the accessory fees for things like eye drops, which were astronomical compared to what they would cost if you got them through the hospital or through a pharmacy. She talked about the upselling around non-medically necessary interventions as part of the on top of the core procedure there. And she talked about less qualified staff, not the physicians in this case, but other staff, nurses, LPNs instead of nurses, being utilized to save money compared to the London situation, which achieved all of the goals that the minister is talking about in terms of the benefits that can accrue from doing some of these types of surgeries in a different venue, a more community-based venue. But that was a public setting, not a hospital, but a community-based clinic or surgery center in London versus the private one in Quebec. So again, why would the minister want to open that door to corporate-owned surgery centers when we already know, based on experience from elsewhere in Canada, of the negative consequences of corporate-owned surgery centers versus publicly owned ones?
Yeah, and again, you know, this is not Quebec. This clinic is not a mirror of what's going on in the Quebec clinic that the member opposite is referring to. There's no upcharges. There's no extra, cost required by the patients. And if he's talking about opening the door, again, I think it would be naive for us not to at least consider some of the alternatives to what's been occurring in the last little bit. But, with respect to the London, where it is publicly run, I think we're quite closely mirrored to that facility. Again, we have the different arrangements throughout the province where we do have clinics run solely by and staffed by the RHAs. But in this particular case, in Bill 3, where we have the particular clinic in mind, up in Bathurst, again, the patients pay with their Medicare card, not their Visa card. And it was interesting because I did quiz some of the staff, because there are a number of nurses there. And two out of the three that were there said they came back from retirement. So this is actually prolonging careers, and it's actually augmenting the staff that's in the hospitals. And the reason they wanted to work for Dr. Giovanni, a very nice gentleman, and we had a good conversation, they said, we like this atmosphere. And part of the things that he can do, which are different than the hospital setting, is that, again, his cost of doing a procedure is actually less than what the cost is in the hospital because of some of the requirements for disinfection of the room, the instruments. Some are reusable, some are disposable. And again, I don't mean to get so far down into the clinical aspects of it because that's not my expertise. But where again, we want to see this as a pilot project where you do monitor all the various aspects to make sure that the goals are being reached and that the patient care, which is number one. But again, in looking at some of the concerns that were brought forward, it again is important to note that this is again improving the service to the individuals, yet it's not costing them any additional money. And overall, at the end of it, the expectation it would cost the province reduced amount because of various components of it. So again, not looking for this to be throwing the doors wide open that anybody can come in, set up a clinic, start charging people, because again, this is setting up the framework, and anything would be evaluated, regulated, and inspected to make sure that the outcomes set up are meeting the goals, which again are reducing wait times and reducing times on the wait list, and again making sure it's not a two-tier, that it's one tier, and it's being paid for by Medicare.
Well, Mr. Chair, we're not here to debate the finer points of a pilot project. We're here to debate and examine the Act respecting surgical facilities, a piece of legislation that will set the legal framework in which surgery centers will operate. And the way this bill is currently written, it would permit corporate-owned surgery centers. So the debate is not around the value of surgery centers operating in communities outside of hospitals for certain surgeries using fee-for-service physicians. That's not the debate. Our party is very much dedicated to community-based healthcare services, and publicly owned surgery centers or surgery facilities within existing or attached to existing community-based clinics makes sense. Will provide all kinds of benefits, Mr. Speaker and Mr. Chair. And so that's not the issue for us. We understand well the advantages of having some of these healthcare services, types of surgeries that can be performed outside of the hospital by fee-for-service physicians at the community level. We know that they can use fewer staff in those settings than you must use in a surgical theater, operating theater in a hospital, for example. So there are benefits. We've argued the same for for abortion services, for example, Mr. Chair. Right now, they are only permitted in hospitals, and we've argued that they should be permitted in clinics. I've argued and advocated for Horizon to purchase Clinic 554, so we'd have a public clinic offering reproductive health care for women and others with uteruses, and to provide abortion services there in a publicly run clinic owned by Horizon. So that's not the issue. The issue is opening the door to corporate-owned surgery centers where there's a profit motive introduced that creates these other problems that you wouldn't have in a publicly owned center. So I guess I want to ask whether the minister had his staff look at the current real estate owned by Horizon and Vitalité, and what the opportunities were for integrating surgery centers into, or surgery services into, the existing real estate that are utilized for community health centers across the province.
I think, and again, not trying to suppose what the minister or member opposite is talking about, but I know in paragraph 3, or in section 3, bracket 2, and section 3, bracket 3, subsection 5.1, and in the preceding one, 2.01, it talks about the Act is amending by striking out private hospital facility and substituting private facility. And I know if you just look at that particular sentence, or those two particular sentences, why the member opposite might make that jump or the leap to say, oh, these are multinational corporations coming in. But that's not the intent at all. The wording, again, is just private facilities. And when you talk about corporations, I mean, the fee-for-service doctors, again, drawing on my knowledge of the profession, most of them are private corporations. You know, doctors set up family practices or private corporations. And, you know, those are entities, are not private hospital facilities. So the RHAs, just putting the next piece of the puzzle together, the RHAs, you know, are responsible for their assets and the management of the clinical day-to-day operations. So again, they do evaluations on a regular basis and look at the needs related to the various procedures. So cataracts was the highest. Hip and knee were number 2 and 3. So when Vitality and Dr. Devante were talking and talking about this arrangement, you know, they worked out some of those details and came to us, and we said, yes, that sounds like a good idea. So the intention, again, is that it's not throwing the doors open, but making sure, again, that this is fulfilling the needs of New Brunswick, the needs of the people in New Brunswick. And this is going to have multiple benefits. People are going to get their cataract surgery sooner. It's going to reduce the wait times, free up the surgery suites in the hospital, which will now expedite the hips and the knees and some of the cancer operations. So, you know, I understand the concern, the member opposite, but again, to alleviate the intention here, or the concern, the intention here is to, you know, have it in a facility similar to this, which is similar to the fee-for-service. But that's not excluding some of the opportunities for community-based practices or family-based practices. So there are lots of things going on at the same time, and this is just one piece of the puzzle.
Mr. Chair, this is an important piece of the puzzle because the minister is choosing in this bill to include, define private facilities as a private clinic or hospital facility established, operated, or maintained by a person, which can be any kind of a corporation, other than the RHA, as defined under the RHA Act. So, for example, he said this is in Quebec, but the major corporation in Canada and operates in the United States too is based in Quebec that operates private surgery centers for cataracts. They own a clinic in Moncton already that's totally private and doesn't offer any things that normally would be covered technically by Medicare, but they would likely be interested in operating a surgery center in New Brunswick. So maybe the minister can walk us through how that would work. So a contract would be entered into with this corporation, and then have we got translation? Do we have translation still? Yep. Yeah, it's still good. Okay. So perhaps the minister can explain how that would work. So this corporation says we want to open a surgery center for cataracts. We already got the space. We've been doing these other things that normally aren't covered by Medicare. So does the RHA enter into a contract with that corporation to operate that surgery center? And then the surgery center compensates the surgeons. Is that how it would work? Or is that how, could it work?
There would be a contract between the RHA and the clinic if that was the recommendation or that was the direction. Or Medicare would pay the doctor, and the RHA would pay the facility. So two separate transactions.
So, Mr. Chair, in the event that this corporation based in Quebec wanted to convert their existing clinic in Moncton to a cataract surgery center, say, would they be able to bring surgeons in from Quebec whose sole purpose would be just to carry out the surgeries and then to return back home to Quebec?
Thanks, Mr. Chair, and I know this is sort of speculation, but again, just to alleviate some of the concerns the member across the way has and some of his other members, there's sort of 3 steps on that whole process before a surgeon could come in from outside New Brunswick. 1 would need to be licensed in New Brunswick, and 2 would have to have the approval of the College of Physicians and Surgeons, and 3 would have to have privileges at a facility, at the hospital. And it's interesting, on the e-visit for New Brunswick, there are some out-of-province medical practitioners, either NPs or doctors or RNs, and they actually have to get licensed here in the province of New Brunswick to give the advice and to write the prescriptions. So that's an interesting nuance, and again, they have to work with the licensing bodies and the associations in order to get those individuals licensed, even though it's a virtual platform. But to do that, so again, just to alleviate the concerns of the member across the way and other people that may have those similar concerns, there would be a process before anyone could come in and set up shop.
Chair, the bill actually doesn't lay out any requirement for the physicians operating in a corporate-owned surgery center to have hospital privileges in New Brunswick. So where would that be required?
Thank you very much, Chair, through you. And that's all covered. The Medical Act, you have to have privileges before you can bill. And again, so there's other legislation that is not Bill 3 that covers the concerns mentioned by the member.
Mr. Chair, can I just clarify that? The minister said that you have to have privileges before you can bill Medicare. There's lots of physicians who don't have hospital privileges but can bill Medicare. Am I not correct?
And again, I think the nuance is there is that, yes, there are doctors in private clinics that can do that. But again, to the original question, can a doctor come in and work in a hospital setting or in a clinical setting related to the hospital? That's how I understood it. You would need those items ticked off.
Mr. Chair, I still don't see the requirement, where that requirement would exist. I've spoken with an ophthalmologist in New Brunswick who's interested in being able to deliver services to their patients in a community sort of based clinic for cataracts. But he too raised the very concerns I had, only in a more learned way, about the potential for this opening up corporate-owned surgery centers. And he had a whole long list of concerns that had to do in part with whether or not those offering surgeries in the corporate-owned surgery centers would have hospital privileges, would be able to do the follow-up, deal with complications, which do sometimes happen with cataracts. I mean, this isn't a kind of a clean-cut thing. It's not just zip, zop, and your cataract's done in every case. There are, by times, complications, which requires the patient to go to the hospital, have follow-up surgery in an actual operating theater to address the complications from the cataract surgery. So once again, we need this seamless connection between what's happening in the community and what's happening in hospital within the public healthcare system. And it worries me that opening the door and permitting corporate-owned surgery centers will create a barrier to ensuring that patients seamlessly get the care they need, if they need it, in the hospital system following an experience in a corporate-owned surgery center. So how's the minister going to guarantee that?
And again, Mr. Chair, just taking the time to be as accurate as possible, because there are various nuances, and there could be a specific situation that the member across the way is trying to get to, or if it's just speculation of what could happen in the future. Again, speculation isn't always advantageous, and we've said this is a pilot project, and any other proposals that are coming in would be evaluated based on recommendations for the needs and stuff. But to get to the specific point that if I understand the question correctly, I mean, you need to have a Medicare number in order to bill Medicare, or for a doctor, for a physician to have that billing number. In order to obtain that billing number, you need privileges. You need privileges from the facility or from the RHA. And that, again, can be within the facility itself, and now expanding it into a clinical setting, that privilege or that protection for the patient would follow. And I know, from a standpoint of follow-up, once a procedure is done within the RHA, that patient is more or less owned by the RHA, and that follow-up would be complete. So again, the speculation of what the member opposite is saying it does cause for a little bit of a stretch, and if there are some concerns of a physician that he's maybe has talked to, if that individual wants to reach out, we're more than happy to try and answer some of those questions. But again, if it's just speculation on what might happen, any of the clinics that are wanting to open up or wanting to expand their services, that again is all going to be in a relationship with the RHA, which would again be based on needs assessment, and it isn't just throwing the door open as potentially as suggested by the member opposite.
Well, Mr. Chair, I disagree in the sense that what we have before us is a bill, proposed legislation, and that an act respecting surgical facilities. So it has no constraints here on what might happen in a corporate surgery center. The minister's referring to other things that are in place, but it's important, because it opens the door to this, that and has no constraints in the bill, that at committee here we examine it from every angle to try and understand what sort of scenarios might play out, so that in the end we can understand what to do in the best interests of New Brunswickers. We already know, we've got the experience in Canada of the difference between community-based, publicly owned surgery centers outside of hospitals versus corporately owned surgery centers that have shareholders to please. And therein lies part of the rub, as it were. So the minister said that there essentially would be two parts to the contract with a surgery center. One would be the arrangement for the fee-for-service physicians to bill Medicare. The other, whatever the amount of money agreed to in the contract between the RHA and the corporation, that would flow to the corporation to, if they're a corporate for-profit organization, to meet their needs, both in terms of costs and their requirements to provide a return to their shareholders. So why would the minister find that acceptable when, if these were publicly run, you would not have that cost whatsoever?
And again, I appreciate the concern the member has, but look, this does not open up the door. And the reason it doesn't is a number of reasons. Existing constraints, existing protections, they exist and continue to exist and will continue to exist under various pieces of the Act, whether it's licensing, whether it's privileges, whether it's some of the billing as well. And when it comes to the components, be it Medicare or facilities, these are negotiated. These are contracts entered into by the RHAs. These, again, are contracts that, are not just open-ended, where anybody can come in, set up shop, and say, okay, we're ready to go to business. Let's open the doors and let the people come in. And this is why we're taking it step by step by step. I can appreciate the concerns the member opposite has, but again, the safeguards are in place. And any of these, again, when we talk about facilities, he's got, one thing in mind, multinational shareholder type, but we have an existing one that's real. It's Dr. Giovanni up in Bathurst. And again, that was a contract that was negotiated, and it would be regulated and inspected, and again, with goals and outcomes that need to be met. Again, making sure that it's based on needs of New Brunswickers, needs of patients, which again are identified through the RHA's collection of data.
Member from Fredericton South, do you have any more questions for the day? Okay, well, we've reached 2 p.m. Meeting adjourned.